Welcome to It's Your Health for another show with myself, Dr. Daniel Benyo, and my smarter and wiser brother, Philip, where we talk about a variety of healthcare topics today.
Alrighty. We'll see you soon. Welcome back to the first segment of It's Your Health. Now remember, anything we talk about, you want to check with your healthcare provider and review in sorted detail. Take notes, write it all down. We try to state some facts, but this may not be good for you. A lot of it might be though. So let's get on to some headlines. TENS unit use cuts fibromyalgia pain in a large trial.
This is an excellent finding. We find that fibromyalgia, if you don't already know, chronic condition, generalized pain, usually 9 to 12 tender point spots along the back, arms, legs, thighs, associated with fatigue, mental fogginess, decreased clarity, depression, anxiety. Is very difficult to treat. Prior treatments in the past have used some questionable methods, or rather questionable risky medications like opioids, which opens up another can of worms. And the TENS unit is kind of a very low risk, low cost approach to treating pain and fibromyalgia.
Good. Moving on. Pot legalization has tied to a drop in opioid prescription rates.
This is an excellent finding. We're beginning to see this is kind of on a lot of headlines, not only medical ones, that legalization of pot, we talk about inhalation, ingestibles, oils, there's different forms of it, and the whole goal is to reduce risk or overuse of opioids, which have their own inherent increased risk of mortality, accidents, overdoses. You see the headlines on opioids themselves, which has been talked about very frequently.
Yeah, certainly. We always, you know, I grew up kind of like with the presidential edict of the war on drugs, and that war on drugs was all the drugs coming into our country. But now the war on drugs is really a lot more domestic. It's you know, our administration is now focusing on the war on drugs here in our own home, and a lot of it's actually prescription drugs. It's not, you know, some of it's illegal drugs, but a lot of it's prescription drugs as well. That kind of ties into a little bit more somber headline. U.S. life expectancy is down. Drug overdose and suicide rates are up.
Yeah, very sad. The U.S. Life expectancy is down by, they said, I think 0.2%. So a small drop, but certainly a drop. And the suicide rates, of course, are up. And we see very commonly as societies advance, problems go from famine and finding food to then more mental health problems. And it's unfortunate. And that kind of ties in too with the opioid epidemic, because we see people who are on chronic opioid use are at risk for suicide, whether accidental, intentional. It's unfortunate.
Alrighty, keeping this pain sequence, let's talk about some of the new things we're doing for pain. The first ever monoclonal antibody infusion therapies are now entering pain medicine. One of the first was Amivig, which is an injectable for migraines. Have you had any experience with it?
Sure, I have a couple patients on it. Sometimes insurance approval is a challenge. The big thing with some of these injectables are reducing overall, at least for migraines, migraine experiences in the month. So if you're getting 15 migraines, they're debilitating, you're missing work, school, what have you, it's impairing your ability to function. We reduce that from 15 to 7, and that's a win in my book.
Right, and what's even more exciting is we're now starting to see some of these style of medications come out for arthritis. We haven't had anything new for arthritis, you know, since Vioxx was taken off the market, you know, and it's in part, that's what's kind of led itself to this opioid epidemic is, you know, our inability to treat pain because of stroke and heart attack risk and all the things associated with the classic NSAIDs. But now that we're using other things for pain, such as medical marijuana, I think it's worth talking a little bit about medical marijuana and cardiovascular disease. Like, where does that fall? Is that something that increases cardiovascular disease? Is it decreased? Do we have a lot of data?
Certainly that it's an evolving study research approach. We're starting to see at least inhalation forms of medical marijuana can increase your risk of cardiovascular mortality, adverse effects. If you have underlying heart disease, certainly inhaling something is not going to be helping you as much in terms of medical marijuana, as well as with underlying lung disease. Now, this is risk-benefit. It depends on where on the spectrum of severity of disease are you, and in what phase are we approaching your aggressiveness of treating your underlying pain versus your other chronic conditions.
And there was a real neat study that just was published from a doctor up in Canada. It was more of a case review about a guy having a heart attack who had stable coronary disease. You know, he had a cath done recently. He's no blockages, open stent, no anginal type symptoms, and he was just started, I think, for his first time using medical marijuana as a pain reliever, and it was a high THC version, and he did not do well. He ended up having crushing chest pain, shortness of breath, diaphoretic, all classic heart attack symptoms. And what the article really talked about is how, from a physician standpoint, the guy felt very unaware of these type of problems, and also didn't really know what to do, and because it's an area that we really don't know a lot about. But I have a feeling because of its use, we're going to have to learn a lot about it.
Now, don't get me wrong, medical marijuana has very good uses, and I don't want the theme to be that we're kind of poo-pooing on medical marijuana. I think it's a conversation that needs to be had about its risks and benefits.
Right. Let's talk about some other things about, pain control. Let's talk about, you mentioned medical marijuana being used as a topical, and that's a big thing. A lot of people are getting CBD oil, even if they're not on a medical marijuana card. You can get that off the internet or anywhere. What has your experience been with some of the topical pain meds? It's
patient specific, I feel like. Some of these compounding medications have meds in them that I would never prescribe orally because of their side effects, and my DEA won't allow me to. But we can prescribe it topically, and in certain patients it can help. And so I think there is a use, and it limits systemic adverse effects.
Last thing, quick question. We were talking about it before the show, that there was some recent studies about women's second shift disorder, increased risk of depression, that's really tied to, a higher risk of depression in women is leading to a lower life expectancy.
Yeah, very interesting. And this second shift that you alluded to is women now are working more full-time jobs, and so there's the stress of full-time work. And then when they come home, there's the kids, there's dinner, there's kind of laundry, and not to say that only women do that, but in some households they do. And so it's almost like a second job, and they're never able to really get off the clock. And so we're seeing in women now who are now working more, their depression rates are going up and their life expectancy is going down, unfortunately.
Right, very interesting study, and I think that's something to think about going forward. That's our first segment, and we're wrapped up and done. This is the fastest half hour in television. We'll be back after these brief commercial messages on It's Your Health. Welcome back to the second segment of It's Your Health, your leader in healthcare information. Let's get back to some headlines. Acute kidney injury linked later to dementia.
Very interesting, and I think some of this is, why does a AKI, acute kidney injury, occur? And usually because of vascular changes. And sometimes it can be seen in someone who's hypotensive, low volume status, which may be, or from an infection, which maybe reduces perfusion in the brain and causes a neurovascular injury that's not really a stroke, but causes changes, and it can cause a risk for dementia in the future. Now, AKIs are very common. Don't think that, oh, I got one, I'm going to have dementia, but it is a risk factor.
Right. I mean, kidney function is just a way to measure what's happening at those vessels. We don't have ways to measure what's happening at that same vessel size in your brain, but if we're damaging ones in our kidneys and we can measure it, it stands to reason we're damaging them in our heart, we're damaging them in our liver, we're damaging in our brain. We don't have direct ways to measure that, but later on sometimes it can come around. Real world results in atrial fibrillation that the new novel anticoagulants, the DOACs, cut deaths by 19%.
Yeah, this is really hammering home the change in how we manage kind of anticoagulation. And it really shows that movement away from Coumadin, warfarin, in certain cases, most cases, reduces risk of death with these novel agents. Really interesting finding.
There's a couple of them out there, and then, you know, sometimes someone will ask me, well, which one's the safest? Well, that's our next headline.
Interesting.
Apixaban, or Eliquis, is the safest effective DOAC for stroke prevention.
Is it DOAC or DOAC? I think
Probably DOAC.
DOAC.
You know, I don't use that. I use novel agent. So you throw these new things at me.
But not too surprising. We've seen from research that Eliquis has lower bleeding risk, lower major bleeding, intracranial bleeds, and whenever you can use one, depending on insurance, of course, Eliquis is what we try to use first off. But there are others out there, and if we need to use them, it's not as though it's a more inferior product or not. We kind of go to Eliquis first, but if we need to use a different one, then we go with that one.
Alrighty, so we're going to kind of do like quick hits here. Like nobody ever wants to sit and put in the long hard work for obesity and help them lose weight. But if you're going to do one fast thing, you know, should I have a Diet Coke or should I have a beer?
My heart's racing. How about water for C?
All right. Well, what if I want, those are the only two on my hand. What's going to actually help me lose weight?
Probably replace one beer with a sugar-free beverage.
All righty.
That's what I would
That makes
go.
sense, I guess.
That goes
That makes sense. Power down or buckle up?
buckle up.
All right, that makes sense too. You know, what's the #1 cause of teenage death? I tell every kid who comes in to get their driver's license, you know, as I'm filling out their form and their parents are cringing, there's a tear, and I'll look at them, I said, what's the #1 cause of teenage death? And they'll look at me, and youth is wasted on the young. I sometimes get cancer, you know, okay, I don't think there's a lot of teenagers dying from cancer. I'll get heart attacks. Again, I don't think there's a lot of heart attacks happening in 18-year-olds. It's car accidents. And guess what it was when my father was that age? It was car accidents. Sure. That has not changed. And that's very preventable. And I think it's even worse now with distracted driving.
Oh, distracted driving is a huge proponent about education and health maintenance in our younger individuals, and older adults don't know that texting while driving can kill. Absolutely,
a big time problem. So let's move on to diabetes and talk about just the overwhelming amount of medications in diabetic world. There's a lot of different things out there. You know, where do you start? Where do we go? Let's try to break it down and talk about some of the most basic things. So a guy comes in, girl comes in, the sugars are in the 200s. You get an A1C because you're suspicious that their sugar's high, because it is high, and their A1C is like 8. It should be less than 6.5. It's 8. You know, so their sugars are averaging maybe 170, 180. Where do you turn first? They have no other problems.
Well, if we were a couple decades earlier, there were really only 3 classes of medications: metformin, sulfonylureas, and insulin. Now we have 10 classes of medications, 40 medications overall. So it's certainly, as you alluded to, much more complicated. And it's really about risk reduction. So as we've alluded to in other segments, using medications that lower cardiovascular risk is a great one. Metformin's always the first line if we can use it. Then sometimes the SGLT2 inhibitors like Jardiance, Farxiga, and then sometimes, depending on how uncontrolled they are, we then jump to injection therapy with the GLP-1 agonist, such as an Ozempic or Trulicity, which reverses the disease process with diabetes, as well as improves cardiovascular risk, as well as lowers weight as well.
Some of the other considerations with all these different med classes is the safety and the cost. Metformin's as cheap as it gets, relatively safe, can be used in a wide variety of populations, young and somewhat old. We got to watch when we get a little bit older. We got to watch kidney function. The newer meds certainly are great. They have better safety profiles, and also, some of them are role reversals. The GLPs, I'm a huge fan of, because they're the only medication that reverses a disease. You know, it reverses the diabetic process. It moves every parameter in the right direction, whereas some of the other meds don't necessarily do that. They'll lower your sugar, but they don't necessarily lower risk. And you're right, it used to be just metformin, a sulfonal, and then boom, you're on insulin. And even the insulin back then was really tricky stuff. Now the insulin we're able to use and mimic a little bit more how life works, and I think that's important to do as well. I think the overwhelming thing at the end of the day is realize that diabetes is not a death sentence. Me putting you on insulin is not a death sentence. We have a lot of steps we can do before we get to that.
Sure.
But it's to use the medications, but realize that it doesn't end, with me just handing you a prescription. Diabetics studies over and over again. It really falls down to the personal responsibility and being able to manage their own health. They have to sit and start exercising. They have to watch their diet. I've had how many patients say, oh, I could have Jimmy's hot dogs because I'm on a cholesterol pill. I can eat as many as I want. That's not what that pill says you can do. I don't remember that being part of the prescription. You need to sit and be a part of that as well. And I think that's where, as a community in general, patients have to sit and start, bellying up to the bar, so to speak, and taking some personal responsibility. That's where I think, we all could do better.
Certainly.
Second segment's over, and we have stuff to cover. We're going to have to sit and pack it into the third segment. We're going to break now for a brief commercial message, and we'll be right back for the third and final segment of It's Your Health, your leader in healthcare information.
Of course.
Welcome back to the last segment, the third segment of It's Your Health. We ought to find a way to do like a fourth segment someday just for fun.
Try.
But this is the last segment of It's Your Health. This is the fastest half hour in television. We're going to try to rip through this stuff because we got a lot to cover. Let's start with some headlines. In the wake of ASPREE, how should we approach using aspirin in our more elderly population who are healthy?
This was a surprising finding. We'll see that in several decades ago, aspirin a day keeps the doctor away. Aspirin was given to everybody, regardless of risk factors or not being there. And we always would give someone after they turn a certain age some aspirin to reduce cardiovascular risk. And actually what we're finding is if you don't have that risk, there's no need to be on the medication because it puts you at risk for bleeding. Ulcers can affect the kidneys as well. So we don't typically just willy-nilly throw you on aspirin if you don't need it.
Right. The ASPREE trial kind of changed a little bit of my thinking for that because I used to be of that mindset that if you're going to take a pill with you to a desert island with the goal to live longer, aspirin should be one of them and probably a statin, even if knowing no other risk factors. But maybe aspirin's got to get off that list and we'll just stick with the statin then. Alrighty. Nearly 9 in 10 teenagers have experienced some type of bullying from online social media.
Yeah, I used to get bullied by you all the time, Phil, so I certainly feel this, but it wasn't online. So I think that's part of the change in that we're seeing a lot of more social media, and bullying used to just take place at school. It's not right, but it used to and probably still does. But then when you go home, that bullying doesn't end like it used to. It stays online, you go online, and we're finding that parents who are not supervising their child's activity on these electronic apps, that we're finding more bullying occurring and excessive screen time, which puts you at risk to being exposed to that bullying.
Right. To draw the allegory from high school, I think that's really the point that a lot of parents don't get. If someone wanted to bully me after school, they'd have to get on the phone. If they're calling from Freeland down to the Valley, you got to pay for that call. So they got to pay 10 cents or a dollar. If they're calling from Mountaintop, they got to pay to make that call. Yell at me, hang up, okay, and then wait for someone else to call. And if someone else was going to call, well, maybe there's a busy signal, and they would wait. Whereas the social media, it does not end, and it has a very crowd mentality, and you can see how people will just start to lob on, and friends that you don't even know that are friends of that friend will just start hating on people for no reason. And then the other problem is try to tell a 14-year-old that this stuff is meaningless and shouldn't be a part of your life. That falls on deaf ears.
Yeah.
But ultimately, they just take that stuff way too seriously, and so we got to find a way to take a break from that screen. It's a big problem, and I think it's going to be a bigher problem going forward. Let's stick with the online stuff. We're going to go to the younger crowd today. Say no to selfies.
Very interesting headline that I read. Selfies are actually increasing the amount of plastic surgery people are getting for themselves because their nose doesn't look right in the selfie picture. And they actually found people taking more selfies are more at risk to getting a plastic surgery to improve their look on how the selfie appears, which is mind-boggling to me.
Yeah, I never would have thought that. I think people are much more self-aware of image in the social media era because we're putting ourselves out there to be judged. But I see people, I'll admit I'm on Facebook. I don't spend a lot of time on it, only maybe 4 or 5 hours a day. I'll see Sammy has selfies every hour. I have to see the selfie of him at the gym. I got to see the selfie of him on the way to work. I got to see the selfie at the desk. I got to see the selfie when we're going home from work. Selfie at the dinner table. It's amazing. People take these constantly all day long, and I don't know what we're looking for with that. But it's a problem.
It is. We should talk to Sammy about that.
We should maybe have an intervention. Alrighty, let's talk about some questions. Someone asked me the other day and said, Phil, you said last week I had GERD, but I think it's reflux. And is there a difference? Are they the same thing? Do we treat them differently? Are we just mincing hairs here?
So acid reflux is acid in the stomach that is coming up and giving that pyorrhea or sensation of burning in the chest. It also can cause a sour taste in the mouth, causing heartburn. We also sometimes say GERD, which is gastroesophageal reflux disease, which is typically found when there's inflammation in the esophagus and much more advanced disease. First and foremost, lifestyle modification is always important. So reducing foods that trigger it, eating large fatty meals, reducing that, not eating and then laying right down, early recumbency. You want to eat and allow 2 hours. And small frequent meals are kind of the big thing. And reduce risk factors for it, smoking, chocolate, alcohol, things like those that can cause reflux. And then if it's persistent, sometimes we'll put you on an acid pill. And then further times we put you through an endoscopy to really look at what's going on down there.
So, all good points. By the way, so I had a patient leave the other day after we talked about a myriad of things, and as they're walking out the door, they pull up, oh, by the way, they pull up their shirt and they show me this thing growing out of the side of their chest and said, what do you think this is? Should I be worried about it? It's been there for about 2 months, but boy, it just seems to be getting bigger. What do you think?
I think it was the keratoma is probably what it is. It could be a myriad of things. It could be a sarcoma, cancer. So whenever you evaluate a skin lesion, is it cancer or is it not, right? Because that's the big thing is, do we have to act really fast on this and get it removed through a specialist, or can I take it off myself and then we'll see what the path results show? And keratoma typically grows really fast. It'll start with a little itching and then it grows fast within a couple weeks to months, unlike some cancers that are kind of indolent and slowly growing. What are your thoughts? You're right. It's a keratocanthoma. On examination, it's almost indistinguishable from a basal cell carcinoma just by kind of giving it the old Uncle Eyeball. The real clue to that is it wasn't there 2 months ago. Keratocanthomas grow really fast. Cancer typically does not do that, at least basal cell carcinoma. Basal cell carcinoma to get this big could take a year or two. Nevertheless, because you really don't know what it is, you got to numb it up, cut it off. If it's on a part of the body that is more sensitive, like in your face, we want to have a specialist or maybe a plastic surgeon or ear, nose, and throat specialist take that off because they'll get it off the first time and not have to worry. But I agree. Lesions, it's good to take a look at them if they're changing, especially. But even if you had them for a long time, I had a guy who came in. He called his sixth toe, and he had this lesion growing out of the top of his foot. It really looked like just a sixth toe.
A sixth toe, but we thought it was a wart, and we took it off. And it ended up being a rather rare type of lesion called a poroma, which I had to look up. And it turns out poromas can have some carcinogenic or cancer features. This one did not. However, they recommended further excision. So he's to go to get a little bit more taken off to get that sixth toe taken out completely. Well, that about wraps up the third and final segment of It's Your Health. Had a lot of fun today. You talked about a lot of topics. Again, you have any questions or concerns about anything we talked about, talk to your healthcare provider. Also, if you have topics you'd like us to talk about, or you have questions about topics you'd like to talk about, reach out to Samsung Productions, Facebook, Instagram, email. They've got it all. Go to their website, send them an email, and they'll get that message to us. We'll make sure we'll address it on the next show. Thank you for all tuning in, and we'll see you next time on It's Your Health.